Okay, thank you to you for the kind invitation. First of all, I just would like to make a short introduction why I am here as a medical oncologist. When Carlo asked me to be the president of this society, and we decided with Dan also to start a new era in the field of cardio-oncology, I was working at the European Society of Medical Oncology in the Educational Committee, and the general idea was to create one global society of cardio-oncology. The major problem is that now there are a lot of people working in the field, and there is no recognized society in the world. So we created one society, and we will have the first meeting in Nashville in a few months, the Global Cardio-Oncology Society. And we will launch a new journal. This is an important information. The journal will be called by Cardio-Oncology, will be published by Springer. The editor-in-chief will be Professor Lipschutz, that will be here in this meeting. And the idea is to have all scientists, all clinicians involved in the field of cardio-oncology in one society and in one scientific journal. This is a very important message, I believe, because as a medical oncologist working in experimental therapeutics, I can tell you that for any phase 1 or early phase 2 drug development, you have a lot of cardiac issues. And so we need a strong partnership with the cardiologist. But I can also tell you that when we design the clinical trial, we are within the advisory board with the pharmas to develop the trial. There is no cardiologist. And so we just discuss about the drug development without considering all the potential side effects. So we need a very strong partnership, and the only way to have this partnership is within one society and within one journal. So this is an invitation for you to submit for the future potential manuscript to this cardio-oncology journal, and secondly, to join this one single society that is the IMCO, because I believe we need to be much more stronger in order to mediate, to change the clinical practice. And after saying this, I will speak about the scope of the field of cardio-oncology. So we know very well as medical oncologists that many drugs that we are currently using can induce arrhythmia, cardiac dysfunction, hypertension, that is a major issue. Most of the tyrosine kinase inhibitors used as anti-angiogenic factors can induce hypertension. What's about the real effect on patients of cardiomyopathy induced by drug? This is an old manuscript published in the New England in 2000. And if you consider underlying causes of long-term survival in patients with initially unexplained cardiomyopathy, you have for sure an effect of chemotherapy-induced doxorubicin cardiac failure. So it's an important issue. Now, we know very well as oncologists that there is a maximum dose to deliver to these patients. So it's not so common now to see these patients. But when we treated patients in the 80s and in the 90s, many of these patients actually have a cardiac failure. So we have to take care of patients that survived to cancer with cardiac side effects. So usually cancer treatment modalities can induce damage on the cardiac function with different time of presentation and with potential approach to mitigate these side effects. So let's speak about anthracycline. We know very well that they will induce damage to myocytes. The time to presentation can go from weeks to decades. The late side effects is a very important issue to be addressed scientifically. We know very well that we can have mitigating strategies like prolonged infusion of anthracyclines, dexrazoxane that is not so used because it seems that can reduce potentially the effect of anthracycline, but it's potentially a drug that can be used. Liposomal formulation of anthracycline, and also the beta blockers and ACE inhibitors. There are few prospective trials, no one large prospective randomized trial, but anyway, we can try to mitigate the effects with this approach. It's very well known trastuzumab, and now pertuzumab and T-DM1. They usually induce something like a cardiac stunning, that the time to presentation can be of weeks, usually is irreversible if you don't use anthracycline first. And we saw a lot of patients with left ventricular ejection fraction decrease induced by anti-HER2 agents. Then we have radiation therapy. I have to tell you that now technology evolved a lot, and the new ways to deliver radiotherapy are less toxic for patients. And it's very important to tell this, because the new approach of radiotherapy in 2020 is completely different from the past. Anyway, many patients may be affected by risk of cardiac ischemia induced by radiotherapy following several years of exposures. Damage on the valves, on the pericardium, and the time to appearance of these side effects can be months to decades. One final message is now radiotherapy can be delivered better, and so side effects are less important with respect to the past. Then we have other drugs that can induce cardiac ischemia, like the fluoropyrimidine. In this case, there is a damage directly on the vessels that can induce cardiac ischemia. It's not so common, it's less than 2% as side effect. Arsenic trioxide is an example of drug that, despite induce a very important QTc prolongation, is an effective drug for treatment some leukemia. And I can tell you that the QTc interval cannot be considered a problem when you have a drug that works. In many of the new agents, the FDA and the European Medicines Agency requires a QTc study in order to develop the drug, and we do a lot of cardiac assessment in these patients. In most of the cases, you have a QTc prolongation, but believe to me, if you have a very good drug that is active, you don't have to care about QTc prolongation, because anyway, first activity and then management of side effects. And finally, there is the chapter of tyrosine kinases. Actually, there are at least 30 approved tyrosine kinases acting as anti-angiogenic factors or also inhibiting specific pathways. In most of the cases, the anti-angiogenic tyrosine kinase induce usually hypertension, and the appearance of hypertension can follow also for days following the exposure of drug. We are now testing an anti-FGFR inhibitor, so the name is lucitanib. We have already published data. And after 4 days of therapy, you have a very important hypertension in these patients. So we need the help of cardiologists to manage these side effects. We don't have any guideline, any consensus. So actually, we are treating patients with kidney cancer, with lung cancer, with colorectal cancer, with drugs that induce hypertension, and there is no clear guideline to manage this hypertension. So we need the help of cardiologists. This is a major issue of research. And believe to me, there is nothing published. There is no consensus. There is no prospective trial, even if we have a lot of patients treated. Which is the risk of heart failure outside clinical trials? So what we present usually are data from prospective randomized trial, in which you have the ideal patient with a perfect left ventricular ejection fraction, no cardiac disease, no hypertension. You randomize these patients, but these are not the patients of the real life. In real life, you have the patient 75 years old with a lot of comorbidities that you have to treat with trastuzumab. You have patients that have no characteristics of the clinical trial. This is a very interesting manuscript published on JNCI two years ago on access to emergency due to cardiac problems, any type of cardiac problems, for patients that received the previous treatment. And if you analyze this data, it's very interesting. Patients who received anthracycline and trastuzumab have a major impact on the cardiac function. We don't know which type of cardiac events are these, of course. This is the limitation of the study. But anyway, this is an access to emergency for a cardiac problem. So if you move to patients between 65 and 74 years, look here, you have much more events. And if you move to elderly patients, the events are really dramatic. You should remember that in all the trials, including trastuzumab as an adjuvant therapy, the maximum age was 65 years old. This was an inclusion criteria. So we don't have data from prospective randomized trial on the use of trastuzumab in elderly population. There is just one trial ongoing in the world, is a trial of the ERTC, in which you use a dual targeting pertuzumab and trastuzumab in elderly or unfit patients. So we dramatically need data because population in the real life is older and older. So we don't have patients of 40 years old in our clinic. In my institution, almost all patients are over 75 or over 65, and we don't know how to treat these patients in the adjuvant setting. So moving back to trastuzumab and anthracycline, we have this type of classification. You can disagree on this, but anyway, I agree on the fact that patients who received trastuzumab alone without anthracycline usually have a reversible cardiac toxicity. So if you deliver doxorubicin and then trastuzumab, usually you have a permanent damage. So this is very important because in most of the cases, the cardiac heart failure observed in the HERA trial, in which I have been involved, they are less than 2%. In any case, they are irreversible because almost all patients in the HERA trial received anthracycline. But if you treat a patient with trastuzumab first line, let's say a patient with metastatic breast cancer first line presentation in which you deliver trastuzumab, pertuzumab, and docetaxel, the new standard of care, if you have a decrease of left ventricular ejection fraction and you stop the treatment, in a few weeks, the patient will recover. So you can restart the treatment because there is no risk of permanent damage. So this is an example of cardiology and oncology partnership. So in the past, maybe you stopped the treatment. In this case, you can restart with the support of ACE inhibitors. And I am sure that this patient, you can deliver the best care without affecting the cardiac function. These are the data from the most important adjuvant trastuzumab trials. This is the time interval between anthracycline and trastuzumab, and this is the incidence of cardiac heart failure. So in the FINAIR, that was a short exposure to trastuzumab, is 0.9 months. Then you have the trial at 0.9%. Then you have the pivotal trial of the NSABP. It's around from 2.8 to 4%. In the HERA trial, it's 0.8. Then in the trial of Dennis Lemon, there was an anthracycline arm and a non-anthracycline arm, and the range was between 0.5 to 2. And in most of the cases, reversibility was reported, but in no trial we have long-term observation of these patients. So, because in most of the cases, some of patients relapsed, they received other treatment, and we don't have information of the other treatment. And so we cannot conclude that these patients have or not have a cardiac dysfunction up to now. We are trying to do this in the HERA trial with the long-term follow-up, and we are contacting the single centers in patients who had a decrease of the left ventricular ejection fraction during the adjuvant treatment in order to understand if they progressed and if they received other treatment at progression and to assess their cardiac situation. In the HERA trial, this is very important. If you remember, the HERA trial was designed to have two arms, 1 year versus 2 years. And if you consider the primary cardiac endpoints, so cardiac failure, there is no difference between 1 and 2 years. But if you consider the secondary cardiac endpoints, so decrease of left ventricular ejection fraction with no cardiac failure, there is a huge difference. So we know very well that 1 year is the standard of care, but a longer exposure to anti-HER2 agents let's say in the metastatic setting where we do the maintenance with trastuzumab and pertuzumab now. In this case, you have major risk of developing secondary cardiac events, in this case, decrease of left ventricular ejection fraction. And these are the change from baseline to rechallenge in the metastatic patients. So usually prior to trastuzumab, this is a very short population analyzed at the MD Anderson. These are patients prior to trastuzumab. They following therapy with trastuzumab. Then they developed heart failure, and then they started a specific treatment, and so there is a recovery. And then you can rechallenge the treatment. Don't forget that in patients with breast cancer, HER2 positive, trastuzumab, pertuzumab, T-DM1, lapatinib, and capecitabine should be delivered. So even if you have a cardiac problem, you have to find a way to deliver this type of treatment. Here I summarized some other drugs that can induce other side effects. Ischemia in this case, so capecitabine, fluorouracil, paclitaxel and docetaxel, trabectedin, and incidence, of course, is between 1% and 3%. These are old data on 68% of risk that I completely disagree. They are published, but it's not the real life. Also, monoclonal antibody like bevacizumab, the risk is between 0.6 to 1.5 to induce an ischemia from bevacizumab. This is the standard of care for colorectal patients. Then erlotinib and gefitinib, tyrosine kinase, the bortezomib for multiple myeloma, anti-angiogenic agents like sorafenib, sunitinib, and pazopanib. Hypertension is a major issue. Don't forget that drugs like pazopanib and sunitinib will induce hypertension in 37–40% of patients. This is a major issue, and absolutely we need something to identify patients that will develop hypertension and to manage this type of hypertension. And then we have the issue of QTc prolongation. I should concentrate just on arsenic trioxide because the other one are well used. You know the issue of nilotinib and QTc prolongation that has been published also in the New England. Most of these drugs have a black box because they can induce QTc prolongation, but the general idea for oncologists, if they work and they can control the disease burden, and if you have a very good cardiologist, we should deliver the drug rather than stopping it. So what we need in the field of cardio-oncology? First of all, we need to better understand classification by mechanisms of cardiotoxicity. So we need preclinical and prospective data on the concept of type 1 and type 2 induced cardiac toxicity. We need to better understand the mechanism of toxicity induced by tyrosine kinase inhibitors. We also need to better understand mechanism of toxicity induced by endocrine therapy. You know that millions of women receive endocrine therapy for 5 years or more in the adjuvant setting, and there is an increased risk also of cardiovascular complication. We need to understand genetic and epigenetic factors that can induce cardiac risk. So when we assess a patient to receive a chemotherapy, we concentrate in many risk factors, but we usually in our anamnesis as medical oncologists, we report just a few information on other risk factors. We need to understand the changes of myocardial structure and function following exposure to drugs, alteration of heart valves, the pericardial damage, effects of radiotherapy, effects on cardiac conduction disturbances. Then we need to invest on imaging, so detection by echocardiographic imaging, the role of MRI, that is also very important, the role of biomarkers. Don't forget the troponin, the BAP, the MPO, other biomarkers that should be discovered. So we need an integrated approach between imaging and biomarkers in order to detect patients that are at risk and to prevent the cardiac damage. Then the follow-up. We have a lot of patients performing every 3 months an ultrasound while receiving trastuzumab, but why every 3 months? Is there any study that can confirm this? Should we do an intense follow-up, a longer follow-up? We don't know nothing about this. These are issues that should be addressed by cardio-oncologists. The preoperative assessment for non-cardiac surgery is also very important. The multidisciplinary approach for cardiac disease in cancer patients, there are no data on this, no data. Then the implications of early detection of cardiac dysfunction or therapeutic approach, the challenges of revascularization, other cardiac disease, the targeted therapies. Then we should address all the concepts related to no pharmacology therapy, risk factors control, lifestyle changes. This is very important, obesity, diet, nutrition. And the role of drugs. All these points are unaddressed in patients with the cancer. So we dramatically need trials that may answer to these questions. And finally, how to deal with patients with no cardiac disease. So cancer is a disease in the elderly. And in most of the cases, you have patients that have a diagnosis of cancer with the cardiac dysfunction, with the valvular heart disease, coronary artery disease, peripheral artery disease. They can be cured from cancer, but we need to address also the known cardiovascular disease. So in my opinion, in the future, what we need, first of all, is to create prospective multi-institutional database and registries. We dramatically need a registry in order to understand all these patients, to classify them, to collect data together. Then we need to remember, this is for medical oncologists, the concept of oncocardiology. Treatment efficacy comes first. So integrate your collaboration with the cardiologist to deliver the better of care to our patients. Then increase the awareness of cardioprotection. In most of the cases, you don't have to stop the treatment because you saw a side effect, a cardiovascular side effect. Speak with your cardiologist and increase the awareness of cardioprotection. Increase the quality of care. You need to identify patients at risk, so the early detection. And finally, I believe will be very important for the future, the genomic medicine applied to cardio-oncology. And I will speak about this in the afternoon. So thank you very much, and I will take questions if you have.